You're listening to Ride Along, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the Ride Along. Well, welcome everybody
To another episode
of the Ride Along EMT School podcast.
And once again, we're a full cast tonight without the missing man formation.
Oh yeah, although I think he's riding on the edge.
He's living that EMS life.
I am living the EMS life. Worked at 24 yesterday, and then today I did a public education event for distracted driving or drinking and driving. It could have been either, depending on the station you were at. And so I spent most of the day over there talking to folks about different things related to distracted driving and drinking and driving.
Well, that would look at you providing service
to the community,
preventative service.
Yeah,
well,
yeah. It was a quiet shift. I'm going to pay for that someday.
Yeah,
like tomorrow.
But no, it was a good thing. Had the opportunity to talk to a bunch of folks and
nice.
Kind of bring light to that issue of distracted driving and drinking and driving.
Yeah. Well, I mean, not to tie it in too quickly into our theme for this week, but I think that's doing quote unquote God's work right there. Because the more education and preventative stuff that we could do for drinking and driving and distracted driving, man, the better off the world will be. Because this week we're going to be talking about multisystem trauma, which is often and very closely related to motor vehicle accidents.
Yeah.
And violent motor vehicle. Like, when you see those terrible traumas, that's where you're probably going to be seeing a lot of that kind of multi-system trauma.
Yeah. I cannot tell you how many vehicles I have dodged in the work truck for people that are just drifting across yellow line because they're doing this on their phone.
Texting.
10 to 1, I probably now run calls when it's a motor vehicle crash. Somebody's a distracted driver versus a drunk driver or an impaired driver. But yeah, I mean, it's a big issue. And so if you're listening, stop texting and driving and wear your seatbelt.
Yeah.
And I don't just mean, I said texting, but stop playing with your phone. Whatever you're doing with your phone, quit it.
Yeah.
Yep.
Oh man, it is so concerning nowadays. And not from the driving perspective, because that is so bad. Like, I think they even have statistics and experiments showing that the texting, the distracted driving technically is worse.
Oh, for sure.
It's all terrible than impaired driving. But like the addiction, and I know I'm probably getting on a high horse right now, but like that screen addiction, I think we're at an age where we're kind of not impervious to it. We definitely suffer from it a little bit, but we're like the last generation that isn't completely integrated and like totally glued to a screen all the time.
100%.
Right.
And I see it in my daughter's generation, and like even so here's a quick anecdote, like EMS related. So we're definitely the old guys, right?
Oh,
Coming
yeah,
into
for
this,
sure.
like
100%.
Like I'm the crotchety old guy that has, high standards and like is totally like not justified in any of my opinions because I haven't been doing this for more than like 15 minutes. But I went to there was a new EMS student who's still in school that came for a volunteer shift while I was there for a volunteer shift, kind of like a fellow ride along. And kids like 17, 18 or whatever, and literally said nothing, didn't talk to anybody, and was literally like just head down in the phone the whole time, was just sitting at the table slumped over, and like was like, "Hey man, what's your name? Blah, blah, blah. Okay." And he's just, And I wish I could say like that's an anomaly, but it like every kid, like it's the default for kids nowadays. And when you find one that isn't like that, you go, "Oh my God, this kid's going to be president someday." Like, like you just have like they're so few and far between. Like that every kid wants to be on that phone.
I mean, it just the Snapchat app. Watching someone use that thing it just immediately raises my blood pressure because all they're doing is making stupid faces and taking pictures of themselves every 5 seconds. It's like, what are you doing? Like, what are you doing? Yeah. What are you doing? Like, it makes no. I am too old. My brain doesn't understand why you're doing what you're doing, and I'm okay with that. But like, there should be an app that parents can put on a car that just shuts the phone's ability to do anything but like just make a phone call.
It would be great.
Just hits a button, cell reception only, no data, just can make a phone call, can receive a phone call.
Forget parents and kids. You know what I would love? I would love the ability to shut off the phone of, I don't know, say an EMS partner who's driving and using Snapchat at the same time.
Don't even get me started.
I'm like, yo.
I had to chew a guy's butt at work. I was like, dude, you're gonna kill us over Instagram, really?
Oh, I'm about.
He did not like that, and it. I was furious.
Yeah,
furious.
I was about this close yesterday from having a chat with somebody who's driving the ambulance that I'm in. Like, I can't even do anything. I can't even reach the wheel. I'm in the back. Like, come on,
punch him in the head.
I can't even reach that far.
I can.
Well, it's but then you're just going to force them to get into an accident anyway.
Yeah, maybe.
Yeah.
Well, the other day, like because I'm trying to do more of like actually do EMT stuff, not just be the volunteer that rides in the back and carries the things. And I started,
it's the progression from observer to provider and like not just assistant, but also leading.
So I'm asking more questions, and I said to the guys, I said, so just out of curiosity, like how do you GPS to the patient? And they're like, oh, we just use our phones. I say, I'm looking around like, where's your phone mounted? No, it's in my lap. And I'm like, yeah, that is such like, buy a $20 phone mount and stick it to the windshield. Like I said to him, why don't you just buy a mount? No, this is fine. And I'm thinking to myself as they're driving, and every 5 seconds they're doing this.
Or they have it in their hand.
Or they have it in their hand. It's like, oh my God.
I have one guy who I've been in there, and this isn't as much of a danger thing as it is just a lack of awareness thing, where it's like he'll take his phone and he puts it on the dashboard directly in front of the steering wheel. Mm-hmm. So he can see it. It's not too far off, but it also means that he does not see the speedometer anymore, which I'm torn on, because technically, like, if you're going with traffic, not a big deal. But when you're driving the ambulance that with due regard, most people treat like it doesn't have to follow those rules. Come on. Like, let's just put it on a phone mount. Anyway. Welcome to the rant of the week. We should have a new segment.
All the comments Max and Mike are old.
No, we shouldn't.
Max and Mike are old.
That EMS people are great at is bitching about stuff.
Oh,
we should not have the rant of the week.
Well, it just means we're finally in it. We're finally part of the EMS system.
Yes.
We can rant. We'll have bonus episodes of just like bitching about like what bags they use on the truck. Inferno. God, those are so yesterday. Yeah. Everybody knows that Stat Packs makes the best bags. Just saying.
Of course.
They do.
They really do. And not just because they're a sponsor, but because they're sexy. They're the sexiest.
They're so shiny and
they're
pretty.
shiny. Yeah. I'm a bit of a gear nerd, and like sometimes I do look down upon other services depending on what gear they're running. Like it's like, if they're running Inferno stretchers, I'm like, come on. You guys can't afford some strikers? What's up with that? And I'm like, I'm so bougie.
Striker's not perfect, but it blows Inferno out of the water.
Yeah. Or you know what? Maybe not even brand, but like
the color.
No, not the color. Like I'm so spoiled in my hometown agency because we have auto lifters. Like we have I don't have to lift the stretcher into the ambulance. It's got the hooks on the back. I forget what that thing's called, but You just roll the gurney up to it, and it lifts the gurney into the.
Oh, you don't have to like hit the
power
button and hold it?
Oh no, you power loader. Thank you. You roll it in, it hooks under the gurney, and then you hit the button and it raises the wheels, but you don't have to support the weight.
Oh, got it.
It supports the weight for you and just slide it in. And like there have been times when I'm at the other agency that we both go in, and I go to like, lift it into the ambulance, or actually it's when it's coming out, and I'll go, oh God, because I forget that it doesn't support the weight. I'm like, good thing I haven't done that with a patient in there.
I've got bursitis in both elbows from all the years of lifting stretchers into the back of the ambulance.
Yeah.
Like, no lie.
I honestly, out of any like piece of equipment that I think is like super bougie and like, really like not over the top, but like something I'm like, that must cost a lot of money. I think that's probably the one that I've come across so far that I'm like, that is a game changer for like, injury prevention. Cause like that moment where you're supporting the entire gurney, like at the back of the ambulance, that could be something that really like injures you. It could.
It's an awkward position to have to brace a lift from.
Yeah. Depending on what height you are and what height the ambulance is at, what the conditions are, if it's slippery and all those things like that. I do think that is a worthwhile investment if your agency has the ability, but you certainly don't have to do it. But it's a luxury for sure.
Yeah.
I would argue that it's almost a requirement. I would say that it's a short-term investment. It is a lot, but it's significantly reduced back injuries. For providers. And because I mean, like if you think about having somebody that's out on short-term or long-term disability, that's a person you're losing. That's overtime you're paying.
Yeah.
That's a hill I'll die on. I think that it's a positive thing. Again, none of the equipment's perfect, right? It's a mechanical device prone to failure. But they really have been a game changer. And EMS providers, back, knees, shoulders, those are very, very common injuries for providers to sustain.
Yeah, the lifting injuries, there's a reason there's a whole block of instruction in school of how you should lift. Like, it's so easy. You know what? I did it yesterday. I screwed up lifting. Luckily, I didn't injure myself, but I totally did not do it the right way. Like there was an older gentleman. He was suffering from anemia. He was just not really. He was really not feeling well. He couldn't walk anymore, and we had to carry him out. And for some reason in my head, I'm like, oh, I should put my hands under his armpits because it's more supportive for him. And then I get over. I'm like, I'm such an idiot. I know how to lift a patient. I need to reach under and grab their arms so that my forearms are supporting the weight. And it's not uncomfortable for them to do that. And I go, why? Like, you just have those moments where you're like, that was stupid.
Mm-hmm. Sure.
Yeah.
And if you're lucky, you don't pay for it.
Yeah.
One of the difficult things related to that is we don't work in a perfect world, and people don't fall or lay in perfect positions, or usually there's furniture in the way. There's some circumstance that doesn't allow perfect lifting all of the time. And it doesn't matter. You can try your best and 90% of the time do everything you're supposed to do, but you're going to come across those situations where you're just not going to be able to apply those proper body mechanics, and you just kind of got to get them out of there the best way you can.
Yeah.
Sometimes it's not the perfect lifting position.
And you hope and pray that you don't hurt yourself.
100%.
Yeah. Yeah. But it is a job that has some risk, which if I'm speaking off the cuff here, is one of the reasons why it's an interesting and enjoyable job, because we get to do something different every day.
This is very true.
You know?
Well, some days it's all the same thing, but still it's something a little bit different each day.
Like, okay, Jonathan, check me on this because I have a theory. This is my first year in EMS. And I'm relatively sure, based on just my own anecdotal evidence, which of course is highly scientific and not biased in any way. I'm pretty sure that spring is old lady fall season.
Yep.
So that's a trick question, Mike. It's always
old lady fall season.
It's always old lady fall
That's
season.
fair. 2 out of 3 calls yesterday were an old lady that fell. And then my last 2 shifts before that, I think it was easily 90% of the calls. And I don't remember the numbers off the top of my head, but out of like, say the last 10 or 11 calls that I've been on, 9 of them have been like old lady falls.
But also we are in Pennsylvania. Pennsylvania statistically has a higher 55 and older community.
Oh no,
right?
I understand. So it's going to be on.
Maybe if you're living somewhere like San Diego, you have less old lady falls and more other things.
Oh, I'm sure of it.
But yeah, for Pennsylvania,
I'm gonna check you guys on that. No, it's always old lady fall season everywhere. All the time.
I had a theory. I was like, well, it's nice. It's getting nicer out, and all these old ladies that have been like cooped inside the house, they're like, no, it's time for me to get out and do things, and they fall, and like, yeah, I guess, you know what? It's always going to be old lady fall. You know what? Now that I think of it, I've been treating old ladies that have fallen for like 6 months.
So this is a segue into actually talking about our topic for the night.
Yes.
But, right, and we're going to get into various aspects of multisystem trauma. But I've been on several calls where just somebody getting up in the middle of the night, an older person getting up in the middle of the night to go to use the bathroom ends up being a multisystem trauma, right? They've got, lacerations. They probably have a head injury and then hips and femurs. I mean, that'll get you every time getting up to go to the bathroom in the middle of the night.
Not to mention the blood thinners that they're on for having AFib.
Yep.
That's it's like a recipe for multi-system trauma. Like all of a sudden you have an internal bleed and a head lack and a head bleed or some crazy things going on. You're like, okay, well, we might have 3 or 4 different things going on here, and that's the way it goes.
I usually work the overnight shift, and I would say 80% is old people getting up in the middle of the night and things happening.
Yeah, well, that's when they realize, oh, I should not have gotten up.
Yeah.
Well, luckily, when they get the call in the middle of the night, that's the lucky ones. Like, they're the ones that are like, oh, at least somebody was there to call, and they're there. Right. And, like, to get somebody there in the middle of the night, I've had 1 or 2, I think, where it was like somebody found them in the morning, and they've been there for like 4 or 5 hours.
Yeah.
And it's like, oof. That's
the worst is when it's 4 or 5 days.
Yeah.
They're not in great shape when you get them, and you got to be very gentle with those people. And if they haven't moved out of that position, there's some things that can occur that you just got to be very careful with them.
Yeah, I've been dispatched twice to calls that were like, oh, there might have been somebody that fell like a couple days ago, and they've both been canceled, which meant that the PD got there and there was no signs of life. Yeah. Like it was, she had passed multiple days ago. But that's what happens, and that's what we're hopefully there to help with. And it's a good segue into, how do we treat these patients that have multiple things going on that are combinations of all the stuff that we have learned in the previous weeks leading up to this. Like our whole trauma block essentially culminates with multi-system trauma for a reason, because it could be any one of those things that we've learned about. So just a quick recap. We've done bleeding and shock.
Yes.
Yeah. That, making sure that we're taking care of any exsanguination. What else?
Soft tissue damage.
Soft tissue trauma.
Yeah.
Like,
which could be a burn.
It could be burns, cuts, lacerations, all like it's a big catch-all, honestly. It's like all the soft stuff in the body that can get damaged. The tendons, the ligaments, like the sprains,
musculoskeletal
strains.
stuff.
Well, that's muscle. Yep. That kind of goes into musculoskeletal, and the broken bones, the broken long bones. What else?
Head, neck, and spine.
Head, neck, and spine. Like,
which we had to split up just because it was so comprehensive.
Yeah, we did head and neck, and then spine. Oh no, it was head and then neck and spine. Because there's so much to worry about with head trauma and head strikes and possible intracranial pressure, right? And then
we did chest and abdominal trauma.
And abdominal trauma, right? Like holes and things going in places they shouldn't be, or damage to the interior, where it's like, what can you do? What can you look out for? How can you start prepping for higher levels of care along the way?
What might have been affected? What are the downstream, things that can happen because of that specific thing being damaged?
So it's like, all of these categories of trauma, you can see how they stack, right?
It's not fair.
It's really not.
Listen. Keep it to one at a time. Moderate your accidents.
Yeah.
Work through one at a time. We'll get that solved. Then you can have the accident for the next area.
It certainly would be an easier day if all these things didn't stack on top of each other. But this kind of leads us, I think, pretty well into our medical term of the week.
It does
because
indeed.
we know how all these things can stack. The question is, how do we classify them, and how do we quantify all of these things happening at once? That's hard to do.
It is.
Now, we refer to all this stuff as trauma, but the medical term of this week is trauma score. So what is a trauma score? It's simply a numeric rating system used to estimate injury severity and survival likelihood, which, if you unpack that a bit, there's some different aspects to that. But really, there's a few examples out there of these scores. They're like a comprehensive score that takes a few different factors into it, and they kind of combine them into a numeric value. Some examples are the revised trauma score, which is it's the one that they went through in our book.
Yeah.
There's also another one called the injury severity score, but essentially they work in the same way. They take things like respiratory rate, blood pressure, level of consciousness, like the GCS score, how well they're perfusing, like what their skin color is, mechanism of injury, like that, how that, the severity of what the mechanism of injury was that would cause the initial trauma. It takes those things into account and then assigns numeric values to them, which can then be tracked over time.
Right.
And those things give us a little bit of an advantage in two ways. One, it helps us determine transport. So, for instance, if you have a trauma score that is more severe than less, that can help you determine whether or not that patient should go to a level 1 trauma center, a level 2 trauma center, whatever your protocols determine in terms of what your decision-making process is for which place you bring them to. But it also helps with statistics over time, because it allows us to classify patients into different trauma categories. And we love data in EMS. Yep. We love data in medicine, and it allows us to track data of, okay, well, these patients of like a very high severity score in this area are surviving, or they have a more likely survival than high level trauma patients in this other system. So then we can look at those two systems and go, why are they doing better here? Why are they not doing as well here? Is it demographic based? Is it location based? Is it system based? Is it provider based? Like, they can look at that and go, all right, let's look at the data and figure out how we make this whole system better in the long run. Right.
Right.
So a couple of great reasons to do it, but it's kind of essential to that process of helping determine the severity of patients that are possibly experiencing multi-system traumas. So, for instance, one of the ones I mentioned was the revised trauma score. I don't know what the non-revised trauma score is. I'm sure there was one for them to have made the revised trauma score, but this is the RTS is what they refer to it as. And I'm not going to go into all of it because some of it is very specific to the RTS. And if you don't use the RTS in your system, there's really, like, it gets confusing because you're taking things that have numbers assigned to them, like a Glasgow Coma scale, for instance. That's a comprehensive scale that has numbers that assign to different motor, eye movement, and speech, right? And that takes all those numbers together. But then the RTS then takes that number and then assigns it to another number based on the severity.
Right. So
like and it's on a scale of 0 through 4, kind of like the GCS is.
Right.
Well, the GCS is 1 through 4 or 1 through 5 or 1 through 6. But say their GCS is a 13, a 14, or a 15. It would give that a RCS score of 4. So that's pretty high on the Glasgow Coma scale, not as severe as some of the lower numbers, right? So a 4 is like a better number for the patient.
Right. The higher the better.
Higher the better. If they have a GCS of 3, that's a 0. And then all the numbers in between also fall into like chunks of numbers. But also, I looked up those numbers. It's not cool. The fact that some numbers are like a single number and some numbers are a group of 3 or 4 numbers. It's not.
Why would they?
It's not easy. Of course, they didn't make it like, even for each one.
No, of course not. Why would they do that? That's just silly.
It's not something that, and we talked a little bit before we started the episode. It's not something like in the heat of the moment you're going to necessarily calculate. Now, I could, at least in the systems I've worked in, but as you're charting, a lot of your charting softwares have the RTS in there. So as you go through and check different boxes and input different vital information, it will spit out a RTS.
Got it.
For you, and so you like I said, anecdotally, you kind of got to walk in and be like, okay, that's pretty bad, and you're gonna treat based on that in the heat of the moment. But this is absolutely important for, like you said, tracking data and is this person going to go to a level 1 trauma center? Or can they go to the local hospital that maybe isn't as capable? Yeah,
it can help you, pull that information together to help make the decision.
Sure.
So the GCS is one of the things. So specifically for the revised trauma scale or revised trauma score, I should say, it's GCS. It takes the systolic blood pressure and assigns different systolic blood pressures to values 0 through 4, and it does the same thing for respiratory rate. So it takes those numbers together. Basically, you add those together, and you have a scale from 0 through 12. 12. I'm not going to say it's good to be a 12 because it means you're being assessed for trauma, but a 12 is the best you can get on that scale. It's like, okay, they're not as severe as they can be. Or a 0 where it's like, that's really bad. Like that means you have a bad respiratory rate, you have a bad blood pressure, a really low blood pressure, and a really low GCS score.
Yes.
And none of those things are good. So that's basically as close to death as you can get. So that's the revised trauma score and trauma scores in general. Now, one thing I wanted to mention here is, and what I found interesting was they taught us about these trauma scales in the book, but we don't use them. Like in what I've been doing and volunteering, I was like, but I have not seen anybody really work with that, and in both services. So I'm like, well, I wonder. And then I realized that there is another answer out there that we do use on a very regular basis, and that is algorithms. So while the trauma scale or trauma score is something that probably gets calculated in our system and where we are in Pennsylvania, because this is going to be dependent upon your protocols. You may have protocols that define what you should do or where you should go based off of your trauma assessments.
Yeah.
So for instance, here I'm using Pennsylvania as an example because I don't have other ones, but I'm sure, Jonathan, you know some of the ones for Virginia or North Carolina off the top of your head. But we have certain things here that will kick a trauma directly into a category 1, which is, hey, they need to immediately get transport to a level 1 or level 2 trauma center as fast as possible. And they even have recommended guidelines for if you can't get them there within 30 minutes, you should call Life Flight right away, start getting an air ambulance on board, right? So those things are like, okay, if they have a GCS motor score, just the specifically motor score of less than or equal to 5, so anything less than perfect falls into a category of get them to a level 1 or level 2. If they have an incident along the way of a systolic blood pressure being less than 90, that falls into automatic category 1. Pelvic fractures of any kind, penetrating injuries, excluding anything past the elbows or the knees. So they have subcategories in here. So if it's a penetrating injury to the upper arms, upper legs, or the abdomen, thorax, head, whatever, that automatically counts towards this kind of trauma category 1. And then if they're none of those, and there's a bunch of them, if it's none of those, then it falls into category 2, which means that they can get to a level 1, level 2, or level 3 trauma center in a slightly more relaxed amount of time. And that's that. Then they start taking into account mechanism of injury. So anything where it's like a fall of greater than 20 feet, if they have any use of a tourniquet to control bleeding, if they're on blood thinners of any kind, they fall into that category 2 section. And then really anything, if they're trauma and they don't fall into the category 1 or category 2, and where we're at, they all finally fall into a bucket of category 3. And basically that's, you can take them anywhere else. Just take them to the closest facility, the closest appropriate facility for what they're dealing with. So that's, to me, that seems pretty straightforward. It gives me hey, they have this, it falls into here, the decision's been made. And that decision is usually pretty much along the lines of take them to either a level 1 or level 2 or a level 3.
Got it.
So I don't have to calculate extra calculation.
For sure.
Things. But yeah, so that's our term of the week is trauma scores.
I think it's important. You have to have a way of categorizing it, even if it's simply for the state and the county, so that they can determine funding, things that should be changed. You need it for that, but also it's a good way for you to determine if there's a questionable level of what you should be doing.
Mm-hmm. And there may be systems out there that work off of a calculated trauma score.
Right.
I'm sure there is. Like if it's a common EMS thing, I guarantee there's at least some system somewhere that have protocols that are like, if they have a revised trauma score of 10, they go here, or so on and so forth. Because it's just another way of classifying and making a decision.
It's a good one.
Yeah, it is system dependent. And I remember through paramedic school when we were doing more like operations oriented classes, there is a guide in the book, but it is going to be sort of specific to where you're at, and what the facilities located around you are capable of. And that's been my experience for the most of my career is this hospital appropriate for this person or not?
Mm-hmm. Yeah. And it's often really, I mean, it gets easier over time. I will admit, like, I understand the way that things work better now that we've been doing this for like 6 months or so. But that was definitely one of the things that felt overwhelming to me when we first started. I'm like, how do you know where to go all the time? Like,
sure.
And you get used to it. You understand the capabilities of hospitals. And then, in your brain creates those kind of like, I mean, really, the brain's an amazing thing because, like, there are some people that have been doing this for so long and they understand how the relationships are. They know the protocols by heart, or they can instantly calculate a GCS score. They can just by intuition because they've done it a million times.
And also, like, the facilities in your area. Like, we're very lucky here in this part of PA that like we have an excellent representation of trauma care, and it's very close by. For both services that you volunteer at, and the one that I volunteer at. So, like, having that immediate resource being right around the corner, it makes your choice very, very simple.
We're very spoiled.
Yes, we are.
We do not have to worry about austere conditions here by any means.
Not even a little bit.
But yeah, so in that greater scheme of multi-system trauma, like the assessment, I think that's a really kind of big theme of this is how, like, where is this patient falling into a trauma category or a trauma score? Mm-hmm. And what decisions are we making even on the BLS level? Because if that's one of the key takeaways I've had from the trauma stuff, not all of it, but especially this multi-system trauma where the name of the game is really a lot of primary assessment stuff. I'm realizing that, like, this is where BLS shines. Like, we have so much that we need to do and keep track of and help patients with that, there's a lot to do there. And, and a lot that we're responsible for, including ultimately the where are they going?
Yeah.
if our big job is transporting, getting them to higher levels of care, that is a huge decision and one that we need to be very comfortable with and know what the capabilities are.
Yeah.
But yeah, so we're talking about multi-system trauma.
We are indeed.
This brings us into our kind of. Did we ever come up with a definitive name for this section? It's the chapter, but like
the meat and the potatoes.
The meat and potato section, really. That's what I've been referring to it as. So who wants to tell us what multi-system trauma is?
I can do it. Or you can do it.
Yeah, go ahead, Max.
Okay. So multi-system trauma is something where it's involving more than one body system at a time. And it's often results from high energy mechanisms like a motor vehicle accident.
Mm-hmm.
So you have something where you have maybe a penetrating injury along with neck and spine injury.
Yep.
So it's affecting more than one place in the body, and it can have descending effects because of it.
Yeah, for sure. And I think the one that's really kind of like the one that I think we always wind up looking for the most is like head trauma plus everything else.
Exactly.
Like head trauma seems to be the one that we were always very cognizant of.
Yeah.
Yeah.
And these patients have a high risk of rapid deterioration. So their compensation can become decompensation very quickly because the body may be good at dealing with one system that's being affected. But when you do multiples, now everything's just going to steamroll down off a cliff.
You mean stacking the problems?
Exactly.
Adds to how difficult it is.
And like you were just talking about, like this often requires rapid transport and to a trauma center, to the right facility. And the idea of having that score and the ability to figure out where they need to go.
Mm-hmm. Yeah, I all of those, like the where they need to go, the priority, that was a huge part of the section of the chapter. I'll kick it off in here because like there's a few different kind of subcategories within the patient severity side of things that I thought was interesting, and they broke it down pretty well. But determining severity was if you kind of like pull it all together, it's like where are they going?
Mm-hmm.
That's a big decision. Like which hospital, and not only just which hospital, but what is the method of transport to that hospital? Are they?
Yeah.
Are we driving them there? If we're driving them there, how fast are we driving them there?
Yep.
Are we trying to intercept with ALS along the way? Because that can be a determining factor for how quickly we move. Or the one that I'm still, I find flight medicine so interesting, but it's like, it might as well be like an angel falling down from the heavens with like on a Pegasus for all I know, because I haven't seen it in real life yet. And we don't need it here.
I just want to call for flight no matter what.
Yeah.
I mean, come on, guys. You want to get sexy in the air and come down and get the patient and save their life. We want to see you come down and grab the patient. So I think he has a splinter, but it's a big one. I think we need flight medics.
I would love to. I want to talk to Chris and Spencer over at the EMS 2020 podcast more about like what it's like specifically to be a flight medic.
Yeah.
Because it's so fascinating. And it's one of those things like you don't really have the opportunity often to go on a flight ride along because there's not a lot of extra space on a helicopter.
It's cramped. It's really, really cramped.
Well, you had a chance recently, didn't you, Jonathan?
Yeah. Unfortunately, no flights.
Yeah,
but that's just how it goes sometimes. I've actually done 2 different ride-alongs, and then just had a flight that I was given. That was my actual flight. Was as part of recognition for something a partner and I and several other providers did on a call. We were recognized, and part of that recognition was getting to have kind of a experiential flight and just see things. But then I've also participated in like on the shift some ride-alongs.
Okay,
but yeah, it's very, very cramped in a helicopter. Depending on the helicopter, a lot of seems like a lot of flight services are going to a smaller bird. And, so the one that I was just on had just a little bit more room. Typically, the way it works is the paramedic sits at the head and then the nurse sits off to the side. And on the smaller aircraft I've been on, I mean, the patient's head is basically in your lap as the paramedic, and in this little bit of a larger bird, there was a little bit of leg room in between there, but not much. But yeah, so
they should fly around in Chinooks.
They really should. Yeah. That's what they need to do. Hey,
as far as flight's concerned, like, and hearing you guys talk and knowing kind of what the layout, because I've, when we've done some other classes, and I've been in the area, I've made sure to check and see the closest appropriate facilities in case we ever had an injury at a class or something. You guys are very fortunate. I mean, within 20 or 30 minutes, maybe less time, you have level 1 trauma centers available to you. And for us, I mean, we're an hour out by ground, and that air medical asset really, really is a benefit. We fly people quite frequently here just because our local hospital doesn't have the capabilities to deal with the kinds of injuries that a lot of people have in these multi-system traumas, or even like cardiac or stroke or burns. Right? These are all different things that we just don't have the capability all the time to take to our local hospital. So
yeah. So just to cover off on that though, but like the decision of whether or not you make that call to bring in flight, that's a huge one. Like in how and where they're going to the hospital, the severity, obviously, that's something that we have to assess, and then the thing that we sometimes don't chat about too much because it's kind of inherent in what we're doing. But there really should be a decision along the way too of like, are we staying and playing, or are we loading and going? Right? Like, should we be limiting scene time to make sure that we're prioritizing rapid transport?
Yeah, and there's key things going on. Like if you've got a stroke victim, you're on the clock.
Yeah,
and you have to go now.
But specifically when it comes to trauma, there may be an instance where we're like, okay, they're not as severe. Is it best to wait for ALS to get here?
Right.
Or do we need to go right now? And if they catch us, if we can intercept, great. If not, we're still a lot closer to the trauma center than we were 5 minutes ago.
Yep.
It's all going to depend. It's going to depend on your location on scene. It's going to depend on how close the ALS provider, or even how far out the helicopter is.
Yeah.
I mean, like I said, our hospital locally may not be as capable as a level 1 trauma center an hour away, but sometimes the patient's been so severe, I need a resuscitation suite immediately, right? Like we're going to take that patient in there and stabilize them before we get them to that more appropriate facility, because they need that immediate stabilization.
Right.
So speaking of the things that kind of lead to those decisions, like the things that make us, determine the severity, like there's a few different categories, but Jonathan, are there any like physiologic criteria that like are like the big red flags for you?
Yeah. So anytime I come up on a scene and somebody has an altered mental status or an abnormal GCS to their baseline, that's going to be something big. Any instance of, we say head injury, and I always like to clarify what we mean is a traumatic brain injury or a possible brain bleed, or any sort of hypoxia that's been caused by this trauma.
Because they present similarly, like with lack of perfusion to the brain, they all kind of leads to that altered mental status too.
Right. And so hypotension, anything where we have a systolic blood pressure lower than 90 is going to check that box. Signs of shock, right, where we're not compensating, or our patient's not compensating anymore. Abnormal respiratory patterns, and in talking about trauma, what we understand with abnormal respiratory rates or patterns, there's a high likelihood of some sort of spinal injury with those, right? So we very, very cautious. So other things that are gonna, and we talked about head trauma, but like starting to see signs of Cushing's triad, right? Where we've got increasing blood pressures and differences between systolic and diastolic are greatly different. We've got that abnormal and lowered respiratory rate, and then we've got
Shane Stokes breathing. We learned about that one the other week.
Bradycardia, So those are going to be some big indicators that we need to be concerned and start considering additional resources. And I feel like a broken record saying it, but really EMS is a lot about logistics and a lot about resource management. So when we start talking multi-system trauma, we're really trying to manage the logistics and trying to get everything, all of our ducks in a row so we can get somebody to the appropriate place and get the appropriate care for them. We've got some different things that may injuries, like injury patterns, mechanisms of injury that may indicate a high likelihood that this person needs to be rapidly taken to a level 1 trauma center. So anything that's a penetrating injury to the head, neck, chest, abdomen, or the groin area, as we talked about with torso injuries, chest wall instability, where we might have a flail segment, 2 or more proximal long bone fractures. My boss last week flew a bilateral femur fracture, and not just femur fracture, but they were open femur fractures. A guy fell 8-10 feet off of a ladder, and so that was an immediate, hey, we need to fly this guy.
So you're not just talking about, okay, so I think if the first thing we're looking for is like vital signs or the physiologic criteria. Now we're looking for the actual physical, like the anatomic things that could happen that are automatically red flags, right?
Correct. Yeah, correct. And that those are the things that have a high risk of mortality.
Yeah, like pelvic fractures, I assume, are part of that too. Like, because they have a high chance of bleeding without stabilization.
Any sort of amputation of and it could be like a finger amputation that probably needs to be taken to an appropriate trauma center.
Yeah, actually, what's interesting is our protocols here in Pennsylvania actually specifically omit.
They do.
Anything proximal to the wrist or ankle is not in like it takes it out of the category 1 and category 2, and it falls it into category 3.
Interesting.
Yeah. Although if they need a tourniquet to stabilize bleeding, to control bleeding, it falls into category 2.
Yeah. Yeah. So if you lose all the digits on your finger, as long as you're not bleeding out, you're fine.
Yeah, exactly. You're category 3. You can go to the closest available.
Go to urgent care, you'll be fine.
Yeah. Well, and the big thing is what's going to be best for the patient in the long run. And for us, because we're so far out, right? So we always talk about time as tissue, right? So being able to potentially reattach a digit or the severed limb, we're on a clock. So for us here, again, it's as you're listening to the podcast, it's going to be so dependent on where you're at, what your system capabilities are, what your hospital capabilities are.
And it's like, I guess these all kind of fall into that category of like, while it may be like, for instance, an amputation, like can be pretty straightforward. Like if somebody just like, if they walk into a helicopter blade or something like that, they lose an arm, like that scene in ER when Dr. Romano loses his arm on the,
it's the best. It's the best ever.
He's such a dick in that movie, in that show. But like at its surface, that is like, oh, okay, well, they lost the arm. They control the bleeding in the arm. Is it really like, is it more complicated than that? And really, these are telltale signs that yes, it could be more because like that event means that they were likely injured in a deeper or more severe way.
Well, it's like we were talking about his boss with the femur broken in 2 places and open fractures.
Yeah,
like you should assume that there's other things going on.
Yeah, falls are a really great example.
If he fell from a ladder and there was that much force involved, there is a good chance he hit his head. He could have a chest contusion. Like there's a million other things that he could be dealing with if there was that much force put into that bone.
And the things that you can't see, like the hemopneumos, thoraxes, the cardiac tamponades, like the things that are like, oh, those will affect, like start affecting them very soon.
Yep.
And the only way you're going to really be able to tell is by either their pain or their vital signs getting worse.
Yep.
Yeah. On that subject, this is, and I only bring it up because it's something fresh in my mind. But we may start to have the capability in our area to start to, look at some of those, the pneumos, the hemos, the cardiac tamponades, because we've just gotten
Doppler
we've got point of care ultrasound.
Oh, nice.
On our response unit. So I'm in the process of learning how to use that. And so we may have some options related to that. But yeah, you're absolutely right, Mike. I mean, these are things in general that most folks are not going to be able to determine in the field. And so the person needs a scan. A couple other things, any open or depressed skull fractures, and then any paralysis, right? And so again, we're thinking, neck and spinal cord injuries.
Yeah.
When we start to talk about paralysis.
Yeah, I mean, that makes total sense. Like progressing from like, okay, categories of red flags being things that we're seeing in the body, like the physiological responses, the actual anatomical things that we're seeing. And then I think the next one was mechanisms, like what are the things that caused it?
Right.
So Max, you want to take us through like mechanisms of injury?
Yeah, because the reality is that can help you predict those potential unseen injuries, like motor vehicle accidents.
Oh, it's
a big one.
It's a big one. We mentioned that was the first thing we started with, right?
Yeah. You have the collisions. You have the injury to the head, the neck, the spine, chest injuries, whether it's through the steering wheel or seatbelt, ejection from a vehicle, which is pretty nasty. Wear your seatbelts.
Yeah, these are the things that we're looking at to go. They're automatic categories for like just in the MOI, right?
Yeah. So you see that, and that's going to lead you directly to person needs to go to Trauma 1 Center.
One of the ones that I always found interesting was death in the same passenger compartment.
Yes.
Yes.
That's always stood out to me as like, and while I understand the reality of life and sometimes shit happens in small, like, in one small area, like it's all death, and in another area, somebody can be completely like fine.
But you have to assume that other person had the same forces put on the body.
Yeah. Which makes total sense.
Rollover crashes, as an example. Like if that car has rolled over, the amount of force that has been put through that body, you have to assume that they're dealing with more than one injury.
And likely the head taking some sort of brunt trauma, kind of hitting the roof at some point.
Pedestrians being struck.
Oh, yeah.
If you're hit by a car, it's a big, heavy thing. You should assume that you have more than just, say, the broken leg that's going on, because they could have gotten run over. They could have been thrown into a curb. It's immediately going to give you that red flag. Okay, they need to get to a higher level of care.
Yeah.
Motorcycle crashes, same thing.
Oh, yeah. Anytime there's a motorcycle crash, I'm assuming it takes a higher level of priority.
My very first call was a motorcycle versus a vehicle. And the guy hit the car broadside and went 50 feet. Enough force that he actually was taken out of his boots.
I've heard of that happening.
Which I thought was very much like, and one of the medic on scene said, seeing that gives you an idea of how much force was put into the body. And whenever they see that, they immediately red flag it as, okay, not only is he a motorcycle versus a car, but there was enough force to take him out of his boots that immediately gives him a higher criteria.
You know what always like gets in my head when I hear about that? And I know this is usually gruesome because like you'll hear about it on like, people who step in front of trains or like, motor vehicle accidents, somebody gets hit by something. I'm like, I wonder how loose people are wearing their shoes. Like, you ever just like, I gotta wonder if they're just kind of slipping their shoes on or if they're tying them. Cause there are some shoes that if you tie them, like I can't imagine a force strong enough to take a foot out of that shoe with cleanly where the shoe stays. It's crazy to me. It's absolutely crazy.
And then you have, go ahead.
Yeah, no, when I was riding motorcycles regularly, I mean, I wore like slip-on boots, like almost like Western style boots.
Okay.
And so I would imagine that those boots were pretty similar
Yeah.
to that style. Yeah.
These were buckle down motorcycle
Oh,
boots.
wow. Then yeah. So that is a lot of force.
Yeah. Yeah. And then you have what we talked about before, falls from a significant height, anything greater than 20 feet.
Yeah, that's our protocols
Right.
in Pennsylvania. Like that, it's specifically listed. If they fall greater than 20 feet, they fall into a trauma category.
And then
That's
blast
pretty
injuries.
standard.
Yeah,
And then you have blast injuries. And that's because not only you're dealing with them being maybe thrown into something, shrapnel hitting them, penetrating their body, but also the force of the wave of the blast doing internal injuries.
Mm-hmm.
So there's like a whole category of things
Yeah.
with that they have to be a red flag.
But I think the interesting thing about this is because there are some mechanisms of injury which are so apparent that it's trauma, like, high severity trauma, like, an arm in a wood chipper. It's like, yeah, of course.
Yeah,
like
exactly.
it's an easy, like it's not sneaky in any way, shape or form. But like the motor vehicle accident, it's like blunt force over a large area. So it can lead to a lot of things that are not immediately seen and that patients may not immediately feel. Like
they may feel fine.
Yeah.
And one thing that I also remember from the book was the idea of penetrating into the vehicle. Like there's a certain measurement that's taken that if you have any kind of movement of the vehicle into the space of the compartment over a certain amount of space, that immediately, no matter if there's no noticeable trauma, they immediately are categorized as level 1.
Which makes sense.
So at that pub ed event I was at today, they brought a vehicle where somebody had been a distracted driver, and the towing company, like they got permission from the individual to utilize this car because it's going to go to the scrapyard at some point. But they brought it as an example of what can happen to you in a car crash. And so starburst on the windshield, massive penetration into the engine compartment, starting into the passenger compartment. Those are all big signs that something's going on. Is the car right side up?
Yeah.
That's a big one.
Was it not right side up? I mean, you could have a car that's sitting on its wheels and its whole top end's crushed in.
Yeah.
Yeah.
But the important thing with the mechanism of injury and seeing that, it helps you determine, your suspicion, like what could be wrong with them. Do they need rapid transport, and do they need a trauma center?
Right. So it's the same thing we've been
Exactly.
kind of chatting about in terms of, recognizing severity. The nice thing is a lot of these protocols basically help eliminate some of that, that processing power that you need to make decisions. And it says, hey, if you see this, do this.
Yeah.
It falls into the category, right? I think one of the things that really does kind of complicate stuff, and this was the next category of severity that they went through in the book, was special patients in consideration. So things
special patients
by its own definition, special means like non-standard, right? Like not the normal. So it's like, what's that little X factor that then makes things even extra hard,
extra worse,
extra dangerous? So like really what it comes down to is like certain patient populations are at greater risk of serious injury. And this kind of ties it around to what we were talking about before, and something we've all seen this season. It seems like it's happened more this season is like old lady falls.
Yep.
Which sounds like a very kind of quaint, like small town in Iowa.
It really does. Old Lady Falls.
Old Lady Falls, Iowa is the premier retirement destination for the Midwest. No, so older folks, our geriatric patients, they are at higher risk of injury, because of their physical condition, but also when they do fall, they have like factors that come into play. They have a lot of comorbidities.
Yep.
and they're more frail. So they have things like the, osteoporosis, where their bones are more easily broken. So that broken bone can lead to an injury in and of itself. And then that broken bone can then cause more soft tissue damage around it, which leads to more bleeding, which leads to all these other problems. Not to mention that these older folks usually have AFib, which is commonly treated through blood thinners. And then all of a sudden the blood thinners make the problems even worse with trauma because now they're not clotting, and it's this cascade of things. So not only is their general physical condition something that makes them more susceptible to injury, the things that you're treating them with, and the injuries that they just stack, right? And that's what we kind of talked about before, is the stacking ideas. Pediatric patients also something we should be very aware of, because kids they experience trauma in different ways. We have a block later, which we'll get into in terms of like specifically things about kids, but like one of the things that we'll talk about is the emotional factor to it makes it even worse. But the way that they react to injury, and like we know, like we've talked about it a bunch, is that kids compensate in different ways. They're really good at compensating until the moment that they're not, and then they fall off the cliff, right?
Which is that I think that's a main not just because they're children, but that idea that you don't know when they're going to fall off that cliff.
Yeah.
So that another one where that clock's ticking, like you have to get them to care.
Pregnant patients, especially trauma related, they have a lot of things going on with their body. They're sharing systems amongst two living organisms. Like those things complicate the way in which the body compensates. And they have extra anatomy. Like the uterus is larger, the baby's larger. They have a placenta. All those things are then extra things that can go wrong and cause additional bleeding and trauma. As a matter of fact, that was one of the things I think. In our conversation with Dr. Kraushorn, when we were talking about the AHATS, was while it's not necessarily trauma related, it was more postpartum, but like postpartum hemorrhaging is something that's like, well, that's unique to pregnant patients or recently not pregnant patients, I guess you would classify them as, but like traumatic bleeding is one of those things. It's like, well, not everyone has a placenta, but that's the thing that's bleeding this time, right? So it's different anatomy and different things that can go wrong on different populations of people. Bleeding disorders, so like the anemia patients or the patients that have some clotting disorders, that and really you can couch the patients that also have that are on blood thinners into the same thing, because it's really the same end result. They can't clot, which means that they keep bleeding. And while it may seem like that's like when you're seeing somebody having a massive hemorrhage and you go, well, that's the clotting's not going to stop it. No, that's actually really what's happening. While a tourniquet can help stop the bleeding, it'll occlude the blood flow through the vessels. Any type of injury or soft tissue damage, all of that needs clotting to stop from bleeding.
And if you have someone that's on blood thinners or has some kind of an issue, like a simple bruise, what would be a simple bruise for another person could be a real problem for them.
Yeah. So, really it's like patients with chronic medical conditions also fall into this category too, like COPD, where patients already have trouble breathing and then they get trauma from to their lungs or to their airways. It can make things even faster, like, go south even faster. So it's the stacking tolerances of trauma. So really, the one thing that I put a note in here for myself, because I thought this was really interesting, because like I've been experiencing this a lot lately, especially in assessments for all these old ladies that keep falling, where it's like the elderly plus blood thinners plus falls plus comorbidities. So all of those things playing together equal EMS.
Yes.
Like that is the job, right?
Yes.
Like, oh, well, they just fell. Yeah, but the reason why they send us, the reason why they send people that are trained to assess patients and not just, no offense to firefighters, because like a lot of them are very good providers and, but like the reason why they don't always send somebody whose just job is to lift them up and put them back in the seat, is because they really deserve to be assessed to go, while it may be a fall from ground level, was there a head strike? Are they exhibiting symptoms of altered mental status? Do they have other neurologic conditions or neurologic defects that are causing that can be popping up? Do they have all of their sensory and motor functions in their limbs? Like, that's what we're trained to do and to assess, so that we know, okay, are they experiencing trauma that is more sneaky than, I just fell on the ground?
Yeah. 100%.
So in that vein, Mike, here's kind of the gotcha of EMS scenarios and testing and that sort of thing. And don't overthink it. But, and I've carried this with me through my career. It's a chicken or the egg kind of thing. Did this person have a medical issue that caused them to have this traumatic injury, right? Mm-hmm. Like, or did they have car crashes and low blood sugars, right? You should be getting a blood glucose on anybody that's been in a motor vehicle crash, especially if they're altered, right? Did they have the heart attack and then they crashed the vehicle? These are questions you should still be looking at, even though you have the obvious trauma in front of you, right?
Yeah.
Is it a medical cause?
Yeah, so totally. And all of those things need to be, like, we need to be looking for all those things. We need to be assessing all those things. And that's what leads to us being able to determine severity of the situation. And we're judging that either by our protocols, our algorithms, or our calculated trauma scores, where we're going, okay, where does this patient fall on this spectrum of severity, and what decisions do we have to make from that? Now, that kind of leads us into, like, all right, we've talked about what we need to assess, the things to look out for, but what about management? Like, what can we do for these patients, right? And do you want to kick that section off, Jonathan? Like the managing patients with multi-system trauma?
So first and foremost, we have to have a method of assessing them, and we do with our primary assessment, right? We start to look at those life threats immediately, right? In trauma, there's a bunch of different acronyms, but the one that we've been talking about is XABC, right? So any exsanguination, we need to check that out, right? We need to check that out, and then we need to deal with it immediately, right? Because these people are, because of all the previous comorbidities we've kind of enumerated, and because of the timeline of, point of injury to the time that EMS is on scene, we are already behind the 8 ball. So we need to deal with those life-threatening injuries immediately upon arrival during our primary assessment. So part of that, depending on the situation, if you're able to do so, disrobing them, right? Trauma naked. That's the term, right? So we've got to expose the areas of the body that we're looking for regarding injuries, and prioritize those life threats immediately. So any uncontrolled bleeding, any airway compromise that we might have, and it could be blood in the airway. It could be, it could be blunt force trauma to the airway that's caused our issue. Any issues with breathing, right? If for whatever reason they may have that spinal cord injury, it's caused an irregular respiratory pattern or irregular respiratory rate, we need to deal with that and breathe for them. And then anything else related to the circulatory system, treating them for shock. But the big thing is having a method and sticking to it. So we're going to do our initial primary assessment and deal with those life threats. And then we're going to systematically go through head to toe and do a trauma assessment and deal with things. And it can be really, really difficult in the heat of the moment to provide care and to take that systematic approach. Just because your adrenaline's up. And oftentimes, if a person has multiple injuries, like we're talking about, you're going to have a lot of people there and a lot of people trying to do things, and something might get missed. So my preference is that you have somebody taking lead on checking head to toe and then you have somebody coming behind them and checking again. That's my personal preference, because it shows accountability in regards to that assessment. Because if one person is checking the lower limbs and the other person is checking the upper limbs, well, who got the torso? Okay.
Right.
Yeah.
Right. So having a coordinated effort is good, but I like the approach of taking one provider taking accountability for the whole body and then doing a follow-up assessment by another provider, just to make sure we didn't miss things. And you're still going to utilize those people that are around there, because you're going to have to move these people and everything. But having one person check those things, again, that's my personal preference. And then, once we've assessed those injuries, then we can start to, divvy out roles, or, prioritize what is important as far as providing care. So,
right. One of the things that the book mentioned that I thought was really smart was the idea of rehearsal. Like we talked about it some when it came to the triangle of life. I think when we were chatting about that a few weeks ago for cardiac stuff, the idea of like everyone has their assigned roles. They do that role or like you may not be in that same role every time, but you know what the roles are, and you can jump into them seamlessly and move around them, or pit crew type CPR, right? I think it's super interesting to kind of take that approach and to train and to practice that in EMS, especially like trauma really deserves that level of preparation and that level of training, even after school. Like, there's so many nuances to like things that may be different. Like, granted, you may know where things are on your truck, right? Like, okay, I know that I know the BVM's in the top pocket of the first in bag. But how often are you pulling out and going into the little pockets and saying, like, where are our trauma bandages? Where are the tourniquets? How often are you actually grabbing that thing and removing it from it to make sure that they're there? Like, getting familiar with that and the actual process of grabbing it and pulling it out sometimes helps really kind of connect those things together.
I just had the exact thing when I was on the truck, because the one of the guys like, you're familiar with the bag, right? I said, yes. He said, do you know where the Narcan is? I said, yes. I said, it's in the medical module. He said, do you know where? Like, that's one of those things that, like, if you need it like now. And just the idea of even if something is as focused as knowing what's in that medical module, so that you can help if you have ALS on truck. That way he's not having to go search for things, and you can be handing off things to him so that he can do his job. Yeah.
Like another good example of that is TXA. I don't know what TXA is. I think it's a clotting agent, right?
Transanemic acid. Yeah. And so it helps keep the clotting factors in the body. Let me pull that up. I want to make sure I give you the correct.
And I'm totally throwing a curveball at Jonathan right now, because I know, like, because I'm very new to this thing, and I know that there's a little TXA kit in our first in bags.
So the big thing that it does is it keeps the body from going into that clotting cascade, or excuse me, it keeps it from like breaking down clots.
Yeah.
Right. So that's the big thing that TXA does. That is an important drug in trauma. They've done a bunch of different studies on it, and as far as its efficacy is concerned, but it does seem to have some benefit in not allowing the clots that are forming to break down. Because remember, we talked about that lethal trauma triad, and coagulopathy, and being able to clot is one aspect of it, but then your body's also, and we do this daily in our bodies, we clot and then we break those clots down, right? This alleviates some of that breaking down of clotting. Yeah. So,
but the reason I'm sorry, go ahead.
No, it's a great drug. But that is, and in multisystem trauma, that's something that we're going to deal with life threats, and then we're going to start to administer that sort of thing.
Right.
Following those immediate life threats.
Absolutely. And the only reason I bring it up is because it's totally not in our scope. Like TXA is not an EMT skill. But the assistance to other providers is totally within our scope. And one of the things that we do best in terms of, a paramedic saying, "Hey, grab me the TXA out of the kit." Me knowing that is a trauma tool, a medication related trauma, that it's within a kit that's within the trauma pocket of our first in bag, to know where to go for it, to know what to grab, and to rehearse in my brain, like, oh, in traumas, I may be asked to hand that kit to somebody. Preparing myself for that, like, makes it way easier. It means that in that moment, somebody doesn't have to go, no, it's that little clear bag, the one with like little lines on it, the one that's in the pocket with, no, I know it. Yep. I got it. TXA kit. Got it.
Yeah.
So like that can save time.
That's it. And that's an interesting kind of, it's interesting that in the systems that you are volunteering and working in, that they do that. So prior to, the last 18 months, we had sealed drug kits, and we still have sealed drug kits, but they were like a tackle box, and breaking a seal on those things was kind of a big deal. So like you couldn't, it would be difficult outside of you cracked one, hey, let's go through this and look at it while we've got it open, to do that. So it's interesting that you guys have certain drugs staged in your bags, whereas like a lot of systems, they have a sealed kit and it is there if you need it. And,
the only ones sealed in the services I've been in is the narcs.
Yep.
Like they're
the narcs. Yeah.
They're in a little safe.
They're in the safe. They do a controlled, procedure in the morning, in evening, whatever, or beginning and end of shift, where they make sure they're there. They inventory them. But I've actually found it very helpful to like go through the bags and go, okay, here's the medication module. And you open it up and, oh, look at that. It's a little tackle box. And I can open that tackle box and like turn the vials and see what, actually read the vials of, oh, that's dexamethasone. And that's
Decadron.
Whatever. Like, I don't know all the medications yet. I'm trying.
It's a steroid.
Yeah. Or diphenhydrameth, the Benadryl. Whatever. Diphenhydramine. Yeah. There's some that I know over the years of working in the pharmaceutical industry, but like, it's good to be able to go in there and go, okay, as an assist role, I can prompt myself to know where those things are. And that requires rehearsal. It requires the foresight to go in and try and prompt yourself to go, okay, this may come up. I need to do this. And that's what I'm trying to get to with, this idea of multi-system trauma. You should practice it with your team. You should talk through it. Like, hey, if this happens, I'm going to ask for this and we do this. If I need this, I need you to grab this thing. I may need, like, if I ask you for a tourniquet, they're going to be in here. And if we run out of tourniquets in this bag, there's more up here in this cabinet in the little bin called tourniquets. So, knowing where those things are and talking through it, super useful.
That is a very important aspect of things. And I tell you, I thought for ease of checking trucks, I would enjoy a system where you had sealed cabinets. On my contract job currently, we've got sealed cabinets, and I've decided I don't like it for the very reason you're talking about, because you can't get your hands on the stuff. You can't oh, okay, this is where this thing is. Now, in general, ambulances are set up mostly the same. But just to be able to like, hey, I've laid hands on this. I know this thing is here. Yeah. That's a super important thing. And kind of to the other side of this, right? We talk about roles and things like that. I believe we've talked about, do the hospitals in you guys systems have, for the trauma teams, do they have like the dots that everybody stands on in the trauma bays?
Yeah. I saw that once.
Yeah. So, and it would be kind of difficult on the EMS side of the house to do that, right? We don't have the dots, but to know that you have certain roles that you're going to fill when you're on a scene, exactly like you were talking about earlier, just being able to know those roles and then step into them and then, to provide the care that you need to provide while you're in that role. Like if you're on the airway, providing that airway care. So,
but like he was saying, if you're going to do the rehearsing, I mean, just having a simple conversation with the medic that's with you of what do you want me to do if this happens, or how would you like me to assess? And it may just be something that happens in the moment on the call, but you should be having that conversation. That way, you know what there's. Every medic might be different, like
they are
exactly.
They are.
like we had one. The guy was like trying to run an IV, and he's like, "Do you know how to spike a bag?" I said, "Yeah." He was like, "Oh, here you go. Do that, please," because that's something I can do for him while he's running the IV into the patient. So
absolutely.
If I can make a plea out there to all those paramedics who run with BLS partners or possible ride-alongs in the back, be open about your preferences and try to be a bit forward at the beginning of a shift to let somebody know and understand that they may not know where you like the heart monitor every time that you get in the ambulance, or they may not know where you think the BLS bag should be, or they may not understand that you are not one of the people that likes to bring anything into a house when you go on a call, and that you will tell whoever you're riding with that they're an idiot for bringing any tools with them. I don't understand why that's a thing, but that I've run into that a couple of times where there's some the guy who's in charge, the most advanced provider. I get it. We're all working on the onus of you. Like you have the responsibility for making sure that all the care is there. But if you really highly think that I should not bring in the bags with me, let me know at the beginning of the shift and not when I'm grabbing them and making me put them back on the ambulance. That would be great.
Yes.
Or just let me bring the bags, please, for the love of God.
He's willing to carry it.
That is
let him carry
uphill battle.
I know. I know.
That is an uphill battle. And I still, as a paramedic working with other paramedics, I still deal with that. One of the things that exactly what you're talking about, I like to, if I have a ride along or a new partner or whatever, I like to set the expectations early on. And I'm not one of those people that this thing has to be here every single time.
Yeah.
Right. That's not how I roll. I like to, drives me nuts. I'm going to get on a soapbox for a second. Rant time. And I've ranted about this before, but
we should have a button that's like EMS rant.
that sound clip, you're going to isolate that, and then you're going to insert that in
with sparkly and kind of we could do it. Oh, I could do a voice with it.
You could.
We could have applause.
We could.
No, where's my
where is your thing?
Oh, here we go. EMS rant.
Anyway, people moving equipment, I get it. You like stuff where you like it, but not treating everybody else like they're dumb for putting, having things the way the truck is supposed to be set up. It drives me nuts.
The way it's supposed to be set up.
Yeah.
The way it's supposed to be set up.
What I mean by that, and let me clarify, what I mean by that is the standard places that things are set up.
Yeah.
Right.
I know.
I've come in and I've had a paramedic completely tear a truck apart and stage things in completely different places because that's where they like them. And it's just come on, man.
Yeah, you have to work
just
to the
get with the program.
Yeah.
I watched it happen. Yeah. I literally watched it happen. I stood there and I'm I had to start paying attention. At first I was kind of ignoring it. Then I'm like, oh, he's moving everything. So
yeah.
Which can come into play that can really throw a wrench in the works when it comes to things like multi-system trauma, where you really should know where everything is.
Guys, and I'll say this, if we're ever on a call together for whatever reason, I want all of the bags and all of the things.
Yes.
I want all of it.
They will already be there, Jonathan.
He's getting the Lucas.
I know they will. I know they will.
Yeah. But he's getting the Lucas. He's getting the pediatric bag. He's getting both spare O2 tanks and the O2 bag. You said everything.
Forget the portable suction, especially when we're talking about multi-system trauma. Do not forget the portable suction.
Yeah. But bringing this all back around, the idea of this coordination, knowing where things are, knowing what your partner wants, limits your on-scene time.
Yes. And that really is a good point, Max, because there's things that you should do, you should practice to do on scene, and there's things that you should have in your head of like, we don't do these on scene for traumas, right? Yes. But like, do you want to, being that you mentioned it, you want to bring us through the list of things that we should prioritize? Like things that we want to limit to on scene?
So with your mechanism of injury, stabilizing the cervical spine during all interventions.
Okay. Yeah, that makes, that should be something that we're doing.
Yeah. If you have something where you have a fall or you have a motor vehicle accident or you have someone that was hit by a car, what if they've had jarring motion like that to their body, you should be suspecting there could be damage to their cervical spine.
And if it's assessed that you should do it, that should be done on scene. Obviously, because you don't want to move people without spinal motion.
The idea of bringing in the portable suction, because you may need to suction the airway.
Yeah, I mean
ABCs. And if you have fluid, whether it's vomit or blood or fill in the blank, making sure you have that suction on scene ready to go. Inserting an oral or nasal airway, depending on mechanism of injury, what's going on, but having that ready so that you can have a maintained airway.
Yeah, I would say anything probably related to the airway in general. Like if you need to open it, that should be done. Like you can't wait to get somebody into an ambulance to get airways worked on. You have to do that right there.
Right. Restoring a patent airway by sealing a sucking chest wound. So if you have a penetrating trauma to the chest or even to the abdomen, the idea of having that occlusive dressing ready to be able to close that, or to the neck in some cases.
Yeah, because it's like, it may not be bleeding. It may not be something that's like, it's traumatic bleeding. We need to stop that right now. It could be deceptive, right? But that sucking chest wound can quickly devolve or evolve, like we learned about in our Pokemon chapter last week.
Yes, we did.
Into a tension pneumo.
If their ventilations are not enough, ventilating with a bag valve, Max.
Yeah.
Like getting the BVM into action and helping them breathe.
Yeah, we shouldn't wait until we get into the ambulance to let them breathe again.
No, that's probably a bad thing.
Yeah.
Administering high concentration oxygen. And that could be something as simple as trying to keep them from going into shock.
Yeah. Well, what you're saying is you should bring the oxygen in to every call.
I had my first case of bringing the oxygen in.
Did you?
The other day. We didn't use it, but we brought it in.
Yeah.
And then controlling bleeding, obviously. I think that goes without saying.
That should probably be the first one in that category.
Because it's the first in our list. It's XABC.
Although, I would say control what type of bleeding.
Yes.
Because that is something that can easily turn into a slippery slope of, we're going to, because if somebody bleeding, is it like trauma bleeding? I assume they probably bleed from a lot of places.
And not to pun what he just said, but if you're slipping on their blood, it probably means you need to control that bleeding right away.
Well, I don't know. I mean, here's the thing. What is the type of bleeding that we should control on scene?
Spurting arterial bleeding.
Is it just arterial, or is it other types of bleeding that could be bleeding too fast to allow for life?
Bleeding.
Yeah, I would say it's not just that, because I don't want to get locked into the it's only if it's spurting out and bright red. If they're bleeding enough from a limb, even if it's venous, like that's something that we should stop right away. Right.
And then there's always go ahead.
Yeah, no, but in the same way that we talked about during our musculoskeletal trauma and splinting someone to death, I've seen people focus too much on superficial venous bleeding, and they're ignoring other life-threatening issues.
Right.
Because that's the red stuff leaking out. That's
obviously, my God, we have to do something about this right now.
And it's not a thing of somebody intentionally doing the wrong thing. It's just you get sucked into the moment and, oh man, I've got to control this bleeding. Well, let's look at this exactly like you're saying, Mike. Is this something that is can I wait to get in the ambulance and do this, or do I need to do this right now? And that's the big question with all these things that we're talking about.
And some of it's not going to, arterial bleeds, easy answer. Okay, yeah, it's spurting somewhere. We definitely need to control that. But the venous stuff, it may be severe enough, like in a limb or something like that, where it's like, okay, well, let me throw a tourniquet on here. And that'll solve it for right now. And then we can move on to something else and not get distracted by, bandaging them to death.
And then restricting spinal motion. And not necessarily a full backboard, could be just one of the KED boards if it's a motor vehicle accident, but it's not just about the neck. It's about the rest of the spine if you suspect injury.
Yeah, definitely. I think that will come into play a lot with, trauma and full body trauma type stuff.
And that's a hotly debated thing, right?
Oh, you missed the debate.
You did. You could have weighed in, but you weren't there.
Yeah. So previous episode, go check that out.
Yeah.
But everybody's protocols are going to be different as to what is the expectation of spinal motion restriction.
Sure.
Right. And some like here locally, using the stretcher as a form of spinal motion restriction is acceptable. Right.
Yeah.
But the big thing is seat collars, like we've talked about.
Yep.
Right. So we're still going to do that, but do we need to fully backboard somebody? And that's, depending on where you're at as a listener, it's going to be different for you. So just make sure you follow your local protocols.
Yep.
I like the idea of the KED board simply because you're doing the spinal restriction, but you're also able to interact with them, moving them out of a vehicle without putting force into the spine.
The big thing about the KED is that it is a temporary solution, right? We're not going to leave them on that if we need to do spinal motion restriction. So, but yeah, in that moving, especially out of motor vehicle crashes,
it's
a good tool.
Yeah.
But yeah, it still falls into that category of like, do we it's not so much always the answer of just backboard everybody.
No,
right?
For
like
sure.
We talked about that a bunch in the spine episode.
Did indeed.
Okay. So we've talked about how we treat patients. The last section in here is, I'd mentioned this before, is some specific things that we want to keep in mind for pediatric patients, because pediatric trauma, while there's a lot of similar principles, there are some things that are some watch outs and some difficulties that make it a special case and enough to talk about it on its own. So, there's a few unique challenges. I think the biggest one that cannot be talked about enough, and we honestly, I can't say I've experienced it, but I just know within my heart that, and I can understand it immediately, is the emotional aspect of children that have been hurt. You want to do everything that you possibly can. You want to go above and beyond. You want to put yourself at risk. You want to not only ease their suffering, their pain, but the pain of the people that are around them, the parents, the loved ones that are with them. All of those things add a whole nother level of emotional stress.
Yep.
And, that cannot be understated. You have to deal with those loved ones, right? Like not only are you dealing with a patient, you have a whole nother extra person usually in there with you that might be hysterical. They may not be hysterical. They may just be so calm and cool and collected that even throws you off about how calm and cool collected that they are. They may be willing to help. They may be working against you because they're trying to frantically do whatever they can for their kid, right?
Yep.
So it's like we may need to remove them from that situation, which again is going to then add another aspect to this of, well, then we have the emotional response from the kid because that parent may be comforting them.
Yeah.
So how are we have to worry about their emotional well-being. They may not know what the hell's going on.
And you may very quickly go from a 2-man team working on a patient to a 1-man team.
Yeah, you could.
But
like, not only are you worrying about their emotional well-being, their kind of processing of this whole thing, but you may also then have to become somebody that's helping explain all the things that you're doing to your patient.
Yeah.
Because they don't understand what's going on. So the need for emotional support and the explanation, that can add a whole nother level of stress onto the situation. And I think, I'd mentioned it before, that sense of urgency really adds on, like I've been on 2 pediatric calls, and even for something that was not an emergent situation, it was a kid who had a seizure. He was not actively seizing. He had one at school. It was short lasted. They met us at the curb. He was standing, even though there was nothing, no immediate life threats, nothing to indicate. I felt myself like, oh, I need to do something right now. Like I need to, And that's just because it's natural instinct when it comes to, hey, we want to make sure these kids are okay. So there's the emotional aspect that can really trip us up. But then there's some physiological factors too. One of which being, like we talk about exsanguination a lot in trauma. They have less blood.
Yes, they do.
A lot less, depending on the size of them. So if they're in a traumatic incident and they're bleeding, they can go to, hypovolemic shock a lot faster than anybody else, like, a larger adult. They progress to shock faster. They may have less obvious signs of injury because kids are stupid. No, they have these like amazing abilities to ignore stuff that I am so jealous of. So they can ignore pain. They can ignore bad things because their brain hasn't really, like, they don't understand it in the moment. So they're like, I'm just going to not worry about that.
Right. Exactly.
They also have an ability to ignore fear, which is pretty awesome. But so like they may not be reacting to spinal injuries or, musculoskeletal injuries that adults would be crying in pain over. So you may want to err on the side of, we may want to spinal motion restrict them more often because especially based off of mechanism of injury, because they may not be reacting to those musculoskeletal injuries or those spinal injuries that, you would suspect them to react to. Right.
Right.
And, the kind of last thing in there is head injury. So kids, while head injuries are bad for everybody, head injuries for kids can be especially hard because understanding a child's mentation is probably a lot harder to do because kids aren't fully formed in the first place. So they may just be emotionally distressed, or they may not be, they don't mentate like an adult does. And we often have trouble understanding, like, is this kid confused or is he just freaking out?
Yeah.
That's one thing, but also their anatomy is different. So they have a much larger head in comparison to the size of their body, which means that it's much more susceptible to motion and like whiplash and things where if it moves the body, the head is going to react a lot more because it has more inertia based off of the rest of the body. So, and a comparatively smaller neck. So it's a much higher chance of being hurt from head injuries.
Not to mention their head isn't fully fused yet. So they still have that movement in the skull. So I don't know if that makes any difference as far as how it presents or not.
Neonates and as, young children. Yeah, for sure.
That actually I don't know if it's a detriment. It might help in trauma, like, cause their head isn't fully formed. So it's probably less likely to get a skull fracture, but I mean, that's kind of neither here nor there, but, sorry, go ahead, Jonathan.
Yeah, no. So as we're talking about these, if I may, I've got story time related to a call. Yeah. Oftentimes I had a call, and I was still in paramedic school, and I was precepting with a good friend of mine who was a paramedic, and this call actually pushed me from the base amount of calls that I needed to get into what they call capstone. So that's kind of like a final set of calls that you need to run. So this was my first capstone call, and this family of 5 were riding down the interstate, and they'd all had a big day. They went to they've got the New River Gorge, and they've got a large bridge that people like bungee jump off of and things like that. So they went to what's called Bridge Day, and Dad was driving. Everybody's tired after the day, falls asleep behind the wheel, and he impacts a guardrail. Guardrail shoots through the vehicle. Unfortunately, nobody was restrained, and it was truly an MCI. Everybody was injured, and the 2-year-old, he was probably the worst injured out of all of them. I mean, he had a femur fracture, he had a basal skull fracture, he had a fractured arm, he had large chunks missing out of his shoulder and the back of his thigh. He was a hurt little guy, man. And the big thing, he was in pain, he was upset, he was crying, but getting dad under control was the big thing. And there were several times I had to like stop and focus dad because he was about to break down. And I'm like, hey man, your son needs you to, stay focused. Okay. So giving that emotional support to the parents in a situation like that, that was a big thing. But he was a very, very sick little guy. And it was, and me as a provider, I felt like I was moving in quicksand, right? A slow motion. Mm-hmm. It took me a good kick in the ass from my paramedic partner to get me moving. But once we got everything rolling, we stayed in there with the trauma team at the ER, and we helped stabilize the kid to get him in a helicopter and get him where he needed to go. But yeah, sick guy, and all these things that you talked about, Mike, are super, super important, especially in that high stress of a situation.
Yeah.
So
I thought that was an interesting thing to kind of end the multi-system trauma on, or at least that block, because it's like you have to worry about all the stuff, right? All of the actual trauma, all of the actual like anatomy and things that could go wrong and the interventions you have to do. And then there are those certain situations where all of a sudden it gets amped up through no physical means, but just emotion. And I think one of the hardest parts of our job is we have to work through that. We have to be comfortable with the idea of, I don't even want to say disassociating, because I think there's a negative connotation to disassociation, but
compartmentalization.
Compartmentalization.
You got to compartmentalize it in the moment.
Yeah.
And do your job. And that's the big thing. And that's what I had to do. And I say, I got slowed up, but it was probably a good 30 seconds that I was just kind of like, I saw all these injuries, or I was discovering all these injuries. And I'm like, where do I start first?
Yeah.
Right.
And, he was a hurt guy, man. Like, so it just, but yeah, in that moment, you have to be able to compartmentalize that stuff and focus on the task at hand.
Prioritize, overcome, or prioritize, make a decision, do what you got to do.
Yep.
All right. So that brings us through multi-system trauma, which actually brings us through our final trauma section of the trauma block. And it's been a ride. It has been a ride. This has been super interesting, and I really think that it's like talking about this stuff the last 5-6 weeks now of our trauma section.
13, 20 weeks.
No, I mean, like in the grand scheme of things, like I feel like we were on like medical emergencies for a lot longer.
We were. Yeah, for sure.
And now that we're through trauma, we get to start getting into kind of like so next episode, or the next big topic is going to be exposure, which is kind of related to trauma, but like the cold injuries, heat injuries, being outside, that type of stuff, which can be another compounding factor onto 100%. The trauma stuff. But still plenty more to go through. And then eventually we start getting into more organizational and system-wide topics.
We talk like formally about MCI, hazmat.
Yep. MCI, hazmat, terrorist operations or terrorist response. I think, and of course, don't forget test prep and all that stuff that we really want to kind of culminate with for, once we get through the curriculum, we want to make sure that we're giving you guys some good content to help prepare for those psychomotor exams and for your test prep for your EMTs exams. So we'll get to that in a minute. But before we get into our test prep for tonight, we have our
tools of the trade.
Yeah, our regular tools of the trade segment.
We're going to have to get stickers for all these. It's going to require story time with.
We need sound bites for all of it. We need like little like tools of the trade.
Exactly. So tonight we're talking about O2 tanks and regulators.
Regulators,
which kind of comes into the trauma block across the board. The idea that it's one of the ways you're treating for shock, and you're treating for shock no matter what.
It comes into everything. Yeah, everything involves oxygen.
Exactly. Yeah. Whether you're getting enough, whether you're not getting enough to certain areas of your body.
So
Oxygen tanks obviously deliver supplemental oxygen to patients with breathing difficulties, whether it's low blood oxygen saturation or signs of hypoxia. And they come in a bunch of different sizes.
Well, yeah, I would imagine that there is no limitation.
No,
technically,
you could probably get, what you should do is just have like a giant tanker just follows you, one of those refrigerator tankers, and you can just hook directly to that and you'll never run out of O2.
Well, that would be pretty interesting.
Yeah.
Have like a chase car with just oxygen
liquid
on it.
O2, But so EMTs for the most part carry small portable units. That's what we have in our O2 bags. There's also usually a larger bottle that is on the ambulance as well that provides oxygen to ports throughout the ambulance.
That would usually be referred to as the main.
Yes, the M or the H tank.
Is that what size they are?
Apparently,
the main.
yes.
Well, an M would make a main M. They're big. They're like the size of. Well, they're probably like 4 or 5 feet tall,
At least.
and probably weigh a significant amount.
Yes, they do. They're very heavy.
They're usually in that outside compartment
are.
next. Yeah,
Yes, they are.
There's usually a compartment. I didn't even realize it at first. It took me a while before I started getting real. Well, it wasn't a while. I mean, it was the first few weeks. So I was like, I should probably go around the whole ambulance and start like looking at what's in all these boxes out here.
Mm-hmm.
And then I opened up one. I'm like, oh, look at that, a giant tank mounted to the door. And there was some other stuff in that cabinet too.
Yep.
I'm like, oh, okay, well that's good to know. And then I also found out that there's usually always a port in by the desk where you can reach in and turn that main tank on and off.
Yeah, there's a little catch window that you can reach through, and you have multiple ports inside the ambulance as well. There's like usually an overhead one.
Yep.
There's another one usually by the little work desk area.
Yeah, depends on what it's weird because sometimes they make sense in where they are, and sometimes they're somewhere else.
It depends on the design of the vehicle.
Yeah.
But the D tank size, that's the portable one that we generally carry on the truck.
Delta.
Delta. Mm-hmm. And usually,
when you say on the truck, you mean the man portable ones.
Well, we usually in our service we have usually 2 spares that are on the truck. They have like a little mounting area in the truck, and then you have a bag that's dedicated for the O2. And that's going to have your tank. It's going to have your cannulas, all the delivery methods.
Well, it's different for everywhere.
It is
because I like my hometown service. There is no bag for the oxygen tank. The oxygen tank lives on the head of the stretcher.
Oh, okay.
Yep.
And that's our portable, and then we have a extra portable that has like a little, almost like caddy on it that's mounted to the wall. It's not like a full bag, like a backpack that fits in. It's more of like a sleeve that the oxygen bag is in. So it's just to say that there's probably a bunch of ways that we haven't even seen yet where those oxygen tanks get mounted and deployed, but I've seen them in a couple of different places now.
And we talked about this earlier, like up until Saturday, I had not yet deployed the O2 bag in any capacity.
Which is crazy to
not
me.
Once.
Like,
not one time.
I've done oxygen like a million times. It's like the one thing I'm actually familiar with.
I mean, like literally asking the medic, okay, I'm grabbing the O2 bag, right? Nope, we don't need that. Okay.
Well, they don't ever need anything.
And asking over and over again to the point where I was like I was blasé about it. And then Saturday he's like, grab the tank. I'm like, I know where that is. So you have the tank. You also have the regulator. So the regulator is going to determine how much liters per minute, which is the measurement of O2, is being put through the different delivery systems.
Right. So the tank itself is. Are they aluminum?
They're
steel?
usually
steel.
They're steel.
Right?
There are fiberglass ones as well, depending. But the ones that I've seen have all been steel tanks.
So they're a steel tank, and at the top is like usually a valve, right? Like that, and really, if you crack that valve, it just puts
all the air comes
all
out.
the air can come out
all the
all
time.
unrestricted, right? And there's a device that has to be mounted onto the tank because I assume that they're way more expensive than the tank is.
I would assume
because
so,
there's
yes.
a mechanical aspect to it, and that thing is the regulator, which restricts the amount of air or the amount of oxygen that can come out at any one time to a measured and controllable rate.
So the tanks are generally pressured at 2,000 psi. That's the actual physical tank itself.
That's it.
And then the regulator brings it down to a working level of 50 psi.
Okay. Yeah.
And that's basically what it's doing. It's restricting that amount that comes out.
Yeah, and usually it's marked in 2 liter per minute increments. for the most part, from 0 to 20.
And I've seen like 0.5, 1, but most of the ones that we've seen have been 2-liter increments.
Depends on the regulator.
Yeah.
That's the short of it. It does depend on the regulator.
And there's different types of regulators too.
There are.
I'm sure there's probably even digital ones if you look hard enough. But there's some that have like almost like the ones that we've usually seen are like twist valves or a twist dial on the side.
Right. So the type that we've been using is a CGA 870.
Whoa, there's a
designation.
very specific.
Indeed. Because I was curious, because when I saw the list of them, okay, so which one do we generally use in our services? And we've been using the CGA 870, and there's different brands of them. But it apparently is a standard for portable medical tanks, size D and E cylinders, and uses a yoke and pins that must align with the holes in the tank stem to ensure only oxygen and safe regulators are attached.
Yeah, that makes sense.
Right. There's other types too. There's nut and nipple type. There's also a continuous flow. It delivers a steady stream of oxygen at a rate set by a dial, so it's not variable. And then there's a conserving regulators that deliver oxygen only when the patient inhales.
Oh, my stepfather had one of those actually on some oxygen tanks. Like it was weird because it would like usually that oxygen tank usually has that hissing like, and I remember coming over at Christmas and he was he had his oxygen tank and it would only go, and like when he breathed, I would hear like, is that a thing? Like I had no idea that it actually conserved the oxygen. It doesn't constantly flow. I'm like, oh, why don't they all do that?
And they're apparently more used for long-term transport or stable patients. So
yeah, well, you have to. Like usually in our situations, that D tank or the M tanker is gonna be just fine for whatever we're doing. But
and the regulator has a couple key components. There's a pressure gauge, is telling you basically where you're at. In our service, there's a range that we look for, and there's a green and a red, and it, depending on where you're at and how full the container is.
Oh, you mean like the dial that's on it? Usually
5 to 1,000, I think. Is what we generally,
like if the maximum PSI is 2,000, I believe. I mean, it depends. I've seen different things. Jonathan, do you have a minimum PSI on your regulators that you're like, oh, if it's above this, it's still considered to be usable and full?
It depends.
Yeah.
In general, yes. So personally, I like for everything to be above 1,000.
Yeah.
But like in the job that I'm currently working on this contract, because of the distances that we're traveling, and this goes more to that M tank, right? That main tank. I want it to be as full as possible. So, I mean, I've swapped them out. If they're below 1,000, I'll swap them out because I might have this person for up to 3 hours or more. Right. And then when we start getting into like, I've been assisting a lot with critical care patients and critical care transports in this role. And those folks that are on vents or like super high flow oxygen, you're gonna burn through a tank. So it's super, super important to make sure you have a full tank when you start dealing with those folks. But in general, on a 911 ambulance, if we've got 1,800, but absolutely at 500, I'm changing that tank. And it's you start getting the money people involved, and they're
like 500's fine.
500's just fine.
Yeah, but no, my big thing is I don't want to get caught not having enough oxygen on a call, so I just swap them at 500 no matter what.
Yeah, I've seen 500 as kind of the standard as point, hey, it has to be above 500. But I personally, I would say I would like them higher as well, just based off of like time, because the more PSI that's in it, it equals more time. And each of those tanks, the reason why they are all different sizes, at least to my understanding, is because really they're different values of time. Yeah. Little side note, which I found interesting. One of the reasons why different PSIs are a thing and why full may not be full for everything is the way that they fill them. Are you guys familiar with cascade filling?
Yes.
So I just learned about this in terms of like how you fill those tanks is like what they usually have is multiple high pressure tanks, and then you bring in the portable tank and you bleed off as much pressure from the first tank in this cascade system as you can, and it equalizes the pressure because you can't have pressure more than one, like when you're filling into a tank.
Okay.
So you fill it into the first tank and then you close that one off, and then you top that off from the second tank, and then the third tank you top it off. So basically you're incrementally increasing the pressure over time, but it can never be more than what the pressure is in your last tank.
Got it.
So if you have a tank that's, 1800 PSI and that's your most fill tank, the bottle that you're filling can never be more
above
than
1800 PSI. That makes sense.
The other aspect of that, Mike, and I would assume that it's the same with oxygen. My experience with this really revolves around SCBAs with firefighting. But if you fill them fast, oftentimes that will heat up the bottle and everything. And so you will not get as much volume in that tank as you could if you slowly filled them. So we try to, at least on the SCBA side of the house, we try to have a controlled rate and not rapidly fill them because hot gases expand more, and so it will initially look like you have a full tank, but then as the tank cools down, you won't have as much air in them. So I hope, and these are big operations. We get all of our oxygen from a vendor that does that as their profession. So hopefully they're not rapidly filling them.
Yeah, at our service, like they fill them on site. Like they bring in big main tanks and they have a cascade filler, and then I had to learn how to do it there, so it was interesting.
I haven't seen it done at our other service yet.
Yeah, I'm sure they will at some point.
So other major components to the regulator, you have the flow meter, which we talked about, the O-ring. Like, it can all fall apart if that silly little fraction of a cent rubber gasket is not there or it's damaged. That's why usually you have multiples there. And then there's something called a power takeoff, which high-end EMS regulators often include 50 PSI diameter index safety system ports.
I'm very familiar with the power take or the high flow valve.
Okay.
I don't know if you remember.
Oh yeah, that's right.
From week one.
Yeah.
It was my first volunteer shift ever. I took the connection line for the nasal cannula and I shoved it right onto that high flow port. Which does not have anything coming out of it normally. Like that's what we plug into for CPAP.
Yes.
But I put that thing on there, and then the paramedic was like, I mean, that's kind of impressive that you even got it on there, but that's not where that goes. Because I didn't realize it goes on the little Christmas tree looking like oxygen nipple. I was like, well, this is round and about a ½ inch wide, and that's round and about a ½ inch wide.
It's close enough.
And I just monkey fisted it on there.
So the question is, how do we use it?
Yeah, I mean, we probably don't need to get too deep into this because we've gone into when we give oxygen all the time, but some tips on actually working with oxygen bottles.
Yeah. I mean, we talked about how full it needs to be. I mean, that's pretty standard. Cracking the valve just to make sure there's any dust and debris out of it before you attach things.
I think, I've heard that several different places.
Yeah, that seems to be another key thing of you should do this.
Now, when you say cracking the valve, what I think, just to explain what Max is talking about, when you take the little white wrapper off of usually there's a protective white wrapper around the valve or around the port. The recommended method is just take that. Well, you might need an oxygen key, which is something that we failed to mention so far. Is like there's usually a small rectangular valve stem on the top of the tanks.
It's a standard size.
Yeah, it's a standard size, and you get a thing called an oxygen key, and it opens up. But a lot of tanks have like a flippy handle that turns that key. So the method is you crack it open just for a split second, just so it blows anything out of that port, and you close it back.
Because you don't want the dust going through the cannula and going into the
through the regulator.
Yeah, any of those things. Then you have various attachment and delivery methods, which we're going to talk about in another tool of the trade.
Yeah.
And then obviously setting the rate, like what's appropriate, what do they need? How many liters per minute is appropriate for that case? If
the device that you're delivering with.
Yeah, exactly.
Definitely that device you're using.
Yeah, you don't want to crank the nasal cannula up to 15.
Exactly.
Like, it doesn't support it.
A little bit of history behind it.
Hold on, wait.
Yeah.
Wait.
Yes. Go.
There is one incredibly important thing that you have to do with oxygen bottles that you did not mention, so you fail.
I did.
And this is a critical fail type of thing that they will ding you for in your practical if you do it. And I'm sure there are NREMT questions. Do you know what the thing that you missed is?
Apparently I don't, because I missed it.
Okay. It is, do not set oxygen bottles up on end.
They get laid on their side.
An oxygen bottle
Please
always has to be laid on its sides if it is not mounted or secured into a thing.
Okay. I was about to say, because I was just about to say, like, those caddies lay them up on their end. But yeah, so it doesn't fall the hell over.
Right. And because an oxygen bottle falling over is a recipe for disaster.
They're heavy.
Well, it's
And
not
they're made of metal.
Turns into a rocket if that valve
They have
breaks.
high pressure oxygen in them.
Because if you do knock that end off where the regulator is, if you manage to do that, it is going to be a missile.
Yeah. I'm sorry.
No, you're good.
They drilled that into me in, I think it was like one of our first skill days, and I felt like this big when one of the, I forget which instructor, I think it was probably
James.
Yep. I think it was him. And he's like, and they nailed it to me. I was like, oh, I didn't know that was a thing. But
As
that
a
makes
matter
total
of fact,
sense.
that became a point of instruction after that at the end of the wrap up.
Yeah, you always have to take
right.
that. Don't ever leave an oxygen bottle up on end. Like it is, and that's universal across all industries, not just oxygen too. Like it's why they have chains around like tanks of stuff, like propane, acetylene, all that stuff. Always never leave an oxygen bottle upright. Unless it's mounted into a thing.
Critical fail.
Yeah, no, I'm sorry.
You're fine.
I'm like, oh my god, that's the one thing we need to make sure everyone knows because they ask that on
and it's an awesome learning point because a missile is not going to be a good thing.
It's like that scene in Jumanji where they have the scuba tanks in the store. What sporting goods store sells filled scuba tanks? By the way, I don't know, but do you remember what I'm talking about? He makes like a sled out of like 2 scuba tanks, and he drops like the weight set on them, and they break the weight that breaks the regulator off, and it shoots to
try and take out the hunter dude.
Yeah.
Yep.
It's a random recall moment. I've never thought about that scene from Jumanji.
So a little bit of history. World War I, the first truly portable oxygen sets were developed by a guy named John Scott Haldane to treat soldiers exposed to poison gas. And these early kits included a pressurized cylinder, a regulator, and a face mask.
So pretty much what we got now.
Exactly. Same thing, same.
Same. Different, but same.
Exactly. In the 1950s, this decade was widely cited as when portable oxygen was first used strictly in ambulances and at the scene of medical emergencies. So that's kind of when things started for O2 in ambulances. Technological push, military advancements from World War II accelerated the development of smaller high-pressure cylinders such as the E-tank, which we talked about in the D-tank.
The D-tank.
The D-tank. Refining delivery, the invention of the different delivery systems. Again, we're going to talk about that in another tool of the trade further on because there's a bunch of different ones you have to be familiar with. In 1970s, there was some standardization. The ISO 32 standard, established in 1977, finalized the international color coding system, ensuring that oxygen tanks were globally recognized by their green color.
I can't believe we didn't mention the green yet.
We didn't. Well, there you go.
That's essential. Green means
is
oxygen, by the way, on those tanks. Like they always have a green top.
Because if you're trying to resuscitate someone with oxygen and use a different gas, it's not going to go well.
Yeah, I don't think people respirate acetylene very well.
Argon or any of those things.
Argon, definitely not. That's an inert gas.
And tanks have evolved from heavy steel to lightweight aluminum and composite materials, making them easier for a single EMT to carry in a jump bag.
Yep, and that's one of the things. I mean, if anybody's still listening, by the way,
they should be.
Hopefully you are. Hopefully you're enjoying this. If you have an extra oxygen tank, a D size, preferably a lightweight one, we're looking for one here at the Ride Along EMT School podcast, and we can use a donation because we're building out our BLS bag for this year, and it's one of those things that I don't want to go out and buy a new oxygen bottle. So we're looking for a sponsor for oxygen.
So if you'd like to sponsor us, reach out at Ride Along
or if there's any other things that you'd like to help us with, we are looking for BLS supplies. So you can reach out at ridealongpodcasting@gmail.com.
So that is O2 tanks and regulators.
Nice. It's one that we use all the time.
Or never.
All the time.
Or never.
All the time. You should be using it.
All the time. You should be bringing it with you all the time. It is the most essential part.
I have championed its carrying in more times than I can count to only be shot down.
You know what? Just carry it. What are they going to do?
It's true. Fire me?
They're not going to fire you. You volunteer. He can't come with us. He does too much.
He's that weird dude that carries in all the stuff.
He's the one that is always prepared. We hate this volunteer.
He makes us look bad. So there you go, guys.
Well, thank you, sir, for our tool of the trade.
Yes, sir.
And I'm sure there is more oxygen stuff to come.
Oh, yes, there is.
But until then, we you know what we should be doing, even though we've already done it, is we should be preparing for tests.
You think?
Or we should be helping our audience prepare for tests. And that's where our lovely paramedic from the South comes in.
He is lovely.
He is. Except when he takes his hat off. That's not so lovely.
Yeah, well,
come on.
I love your new haircut, I swear. You look like Walter White, you know?
No.
Yo, Mr. White.
But we have
right.
our student tip of the week and test prep with Jonathan.
Everybody's favorite section.
All right. Are you guys ready for some questions?
Hey, we're looking to get
Always.
3 out of 3 again, sir.
Yeah, we're 2 weeks
Let's
in a
see if
row,
you can
3
do
for
it.
3.
All right.
We do not look at these questions, by the way. I swear. We're honest. Scouts honor. Well, we will not cheat.
We will not cheat.
I don't send them the answers either.
That's true.
He doesn't.
All right. So, first question. You arrived first as an emergency medical technician at a motor vehicle collision involving multiple patients with unknown injuries and additional units en route. To ensure effective overall patient care, which action should you take first? 1. Wait for additional units before acting. 2. Establish command and perform an initial scene size up. 3. Begin transporting the closest patient immediately. And 4. Start completing documentation. What is the most appropriate answer for this question?
So we're going to use our usual method of ruling out the ones that are silly.
Yes, I think we should rule out the ones that are silly. They're all silly. We should literally just start doing paperwork.
I was about to say there's one that is in particular very silly.
What are you talking about? Like that's immediately what I go to is I'm just going to start writing stuff down and
exactly.
You can find me later. I'll be in the cafe near the crash site.
Could you please stop screaming because you're on fire? I'm trying to fill out my paperwork.
Sir, what is your social security number and date of birth? Sir.
Sir.
Why aren't you speaking, sir?
Can I get your insurance information, please?
So I think the first one that should be limited right off the bat is start completing documentation because it's just the silliest.
Yes.
Of the answers that are there.
Very true. I think the other silly one, is wait for additional units before acting. Whatever you do, don't wait. Like, you should be doing something. Like, we get trained to help. Mm-hmm. We do not get trained to sit timidly by the sidelines and wait for someone else to come by and tell us what to do. The whole process of becoming an EMT is to be an independent thinker and to help the situation at any time. So,
and another silly one that gives away the actual answer we would go with, in my opinion, is beginning transporting the closest patient. Exactly. The closest one to you, regardless of what condition they're in, just grab that person, throw in the back of the ambulance, and leave the rest of them behind. Because, I mean, after all, there's more people coming, right? They'll take care of, who's left.
Yeah.
That makes perfect sense.
I think this is definitely one of those questions that leads you through the process of, like, if you eliminate all the ones that sound silly, it only leaves the one left, which is the answer that nobody wants to be true, honestly. Because no EMT wants to show up at an MCI and all of a sudden have to establish command of
anything
because we're all new to this. and performing an initial scene size up. That's certainly within what we do, but I don't think anybody really relishes the opportunity to be like, oh man, I get to coordinate a bunch of extra units that come in and be the on-scene commander. And then my partner, who's probably an advanced provider, then goes off and becomes the triage officer. And I don't even get to work with them. And I have to coordinate all the other stuff that comes in and then take care of fire units that have to do stuff. Yeah, I totally want to do that. Not.
Nope. So our answer collectively would be B, sir.
Yeah.
All right. That is the correct answer.
Nice.
1 for 1.
We'll talk more about MCIs and stuff and ICS systems coming up in further episodes.
There's a theme in these questions because I knew we were doing multi-system trauma.
Oh, so. Sweet! You actually found questions that were related to trauma stuff.
Yeah. So, all right. Question 2. A 28-year-old patient involved in a motor vehicle collision is found still restrained in the driver's seat. The patient is conscious and alert, reporting neck and back pain. Which question or command best assesses for a possible spinal injury during the neurological assessment? 1. Can you lift both legs and hold them in the air? 2. What day of the week is it? 3. How did the accident happen? And 4. Can you squeeze my hands?
There's one there that, depending on what's going on, would be a neat trick to see.
All right, what's your confidence level, Max, on this one?
Oh, very.
You're very confident?
Oh, 100%.
Okay. I'm probably overthinking this one, which I tend to do. So the patient is conscious and alert, reporting neck and back pain. Which question or command best helps assess for a possible spinal injury during their neurologic assessment? Okay. So which one would you eliminate?
Immediately, can you lift both legs and hold them in the air?
Seems a little much.
And if they're not like seated, are you David Blaine? Like, can you float in the air?
Mm-hmm.
So I would eliminate that one.
Okay.
And if I was going to eliminate another one that's clearly silly, it would be what day of the week, only because of what you're trying to assess.
Right. Like that's a good way to assess mentation, but it is not a good way to assess possible spinal injury.
Yes.
So I would agree. It's tricky though, because you go, oh, well, that one looks different than the other three
and
questions.
It's part of the neurological exam.
And I'm supposed to ask that question, but not for that particular reason. Exactly. So they're crafty with these sometimes. So that leaves with, how did the accident happen? And can you squeeze my hands? Now, how did the accident happen is actually really part of it's the same category as question as what day of the week is it? Because that's oriented to event.
Exactly.
It could also help understand mechanism of injury, but still, both of those are not telling whether or not a spinal injury happened.
Right.
So I would say, like, my initial I was not a 100% lock, because I'm like, oh, this is a crafty answer section, or a crafty selection of answers, I should say, that make you think and go, let me double check the question and make sure that I'm going in the right direction. So I would say it's, can you squeeze my hands, which helps, assess whether or not somebody has motor function and sensation, and that they're performing equally on both sides.
Yep, that was me too.
You are both correct.
Yes,
2 for 2,
two
baby.
for 2.
All right.
We're on a streak.
Let's see.
I can't wait until Jonathan's going for his critical care cert and we can ask him questions.
Yeah.
We should definitely do that.
Yes.
Oh, we will. It's going to happen.
All right. So, an adult patient is found pulseless and apneic, and an emergency medical technician begins high-quality cardiopulmonary resuscitation with chest compressions. Which complication is most commonly associated with performing chest compressions in an adult? 1. A lacerated spleen. 2. Gastric distension. 3. Fractured ribs. Or 4. A fractured clavicle.
I am a 100% lock.
You are.
Mm-hmm. What about you?
I think I'm a 100% lock, but I could see how it could be two different ones.
So that's not 100% lock.
It's not 100%.
You're like
it's 95.
like a soft 65% lock.
It's like 95%. There's 5% in there for.
Okay,
you
so go ahead, Jonathan.
Process of elimination. I want to see what you guys come up with.
Well, I also let's just reiterate the question: which complication is most commonly associated with performing chest compressions on an adult?
Yes.
So, which one of these things happens from performing chest compressions?
Yes. So let's start with the one that's not even close to the same area.
Well, there's two that aren't really close to the same area. So lacerated spleen.
Yeah.
It's not in the chest.
Nope.
So I would say that shouldn't be on the list.
Correct.
Although people are going to be like, "Ooh, a lacerated spleen. That seems like it's really bad. I should probably consider that." But that's not.
Nope.
It's not a byproduct of chest compressions. Gastric distension is also not in the same area.
Yeah, completely different part of the body.
However, sneaky answer, because gastric distension can happen from the process of CPR if you're including rescue breathing or ventilation, because that can be a complication of air getting into the stomach.
Which is what I was thinking.
However, if we go back to the question says, which complication is most commonly associated with performing chest compressions on an adult? So I would say the chest compressions is the key thing to kind of keep you on track there. So that leaves fractured ribs and fractured clavicle,
which are both in the chest.
Yep.
But the clavicle generally is not going to be impacted by chest compression.
Right. The clavicle is the breastbone, right? Lives above the area where you're giving compressions. And fractured ribs are directly connected to the sternum, or not directly. They're connected through cartilage, cartilaginous tissue. So my lock on this from the start was fractured ribs because, I felt it. when I gave CPR, although I don't know if that's technically fractured ribs or just cartilage, cracking, either way. But as soon as you give chest compressions, you have that classic.
Ooh, that's real.
Yep. Oh, that's there. That's a thing.
So yeah, same.
Okay, so you guys are locked in on fractured ribs.
Yes. That's what I'm going with.
You are correct.
Yes.
3 for 3, baby.
3 for 3. Yeah, we're EMTs.
That's right. We can prove it.
So, and it's, it's definitely a possibility. You get the little old lady who had fallen and she's in cardiac arrest now, and you're doing CPR on her, and Max comes in and gives total effort. It's a possibility you could fracture her ribs. But
I want to squeeze the heart to the size of a pancake between his spine and the sternum. That's what you're supposed to do, right?
But you need to let it have recoil, and so it can refill.
And then back to 6 inches of penetration, and then back to 6 inches of penetration. No, I'm kidding.
Yes. So we did it.
We did
3 weeks in a row. 3 for 3.
That's right.
I feel better. At first week was rough. We had a couple of questions that were like, "Ooh, that one's."
Some of them are tricky. I mean, even for me, like some of them still trip me up when I'm going through and just kind of refreshing and taking some of these questions.
But honestly, I think that's the fun of this is like, even though we've gone through it, it's the vulnerability. We are opening ourselves up to possibly being wrong, which is part of the process of learning. You have to be able to be willing to be wrong to learn.
And I think if you've got your certificate, even if you have your certification, if you're volunteering or you're hired on, you have downtime. It's if you're paying for it anyway, it's a really nice use of your downtime. Mm-hmm. It's just going to keep you fresh. Absolutely. Keep the brain working.
So keep on your pocket prep and keep on your studying, guys, because it's important.
Absolutely.
Yeah, you just have to remember that testing is its own skill, right? Just like we talk about all the other EMS related skills, when we talk about testing, it's its own skill. So you've got to flex that muscle and build that neural pathway to be able to read the questions and then eliminate the answers till you find the correct one.
Mm-hmm. Yep. All right. So we've made it through multi-system trauma and our tools of the trade and our student tip of the week. Thank you, Jonathan, for guiding us along the way, and we cannot wait to return the favor for when you are going through your next exam prep. So
we're going to spend a week on the first 3 questions. Not that one. That one.
Honestly, I'm kind of interested to see if I would even be able to answer some of the high level provider, critical care questions, because there's so much in like the scope of paramedic that seems like it's out of so far out of my reach that when you add on even more additional stuff, I'm like, man, this is gonna be nuts. Bet you there's questions on like bilirubin and lab results and weird shit.
Let me give you a hint, because I've been taking some of the FPC questions or doing some of the flight paramedic questions and the critical care questions. There are.
Yeah, it's like a lot of like labs and like all that stuff that doctors know, like that they can look at and go, hey, you've been eating too much red meat lately. Like that you'll be able to tell all that stuff. All right. Well, thank you all for
the look on his face when you said that. Yeah. Like, what?
Well, thank you guys for the episode, and thank you all for taking the journey with us. We'll see you next time on the Ride Along. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols. Heartbeats racing in a